Thank you, Miriam. Okay, so I'm really pleased today to talk to you about the DAMP&D study, improving the detection, assessment, management and prevention of delirium in hospices. This study is funded by Yorkshire Cancer Research. It's actually currently ongoing at the moment. It'll run until February next year. So I'm presenting to you today some early emerging findings. So I'll start by giving you an overview of the study itself, and then we'll look at some of our preliminary results we have from one of our hospices, and then I'll give you a summary of our progression so far. So delirium is common in palliative care patients, and although there are established clinical guidelines on the management of delirium, they're often not well implemented in a hospice setting. So with this in mind, the overall aim of this study is to underpin a future national quasi-experimental study that will test the use of an implementation strategy that's been designed to improve guideline-adherent delirium care in hospices and see if it's associated with improved patient outcomes, so i.e. reduced numbers of days with delirium. So the study consists of 3 work packages and they're intersecting, and work package 1 is an experience-based co-design. So staff and volunteers from the participating hospices, together with public involvement members, will meet online for 3 workshops throughout the duration of the study. Together, we'll refine an existing implementation strategy called Creating Learning Environments for Compassionate Care, or CLEC. This was developed by Bridges et al., and it aims through workplace learning to develop practices that enhance the capacity of the entire team. But it was tested in acute hospital settings. So together in these workshops, we want to refine this strategy so it's more appropriate for hospice settings. So moving on to work package 2 then, the feasibility, where the aim here is to systematically and reliably collect data, including a delirium diagnosis, from the clinical records in a way that minimises burden for both the patients and the families and also for staff. So how are we going to do this? Well, we obtained special ethical approval so that instead of obtaining individual patient consent, opt-out posters go on display in the hospice, as well as individual opt-out leaflets in the patient admission care packs. The hospice then collates 50 patient care records, and we carry out a case record audit. Now, to do this, I use a modified version of a validated tool developed by Inoue et al. And this enables me to retrospectively identify delirium in case note records. The 12-week implementation period then commences, and it's marked with a study day that's in person with as many staff and volunteers that are able to practically attend at the hospice. The morning session focuses on delirium, so that's training and education, and the afternoon focuses on the CLEC-PAL implementation strategy. So once we've refined the CLEC so that it's more appropriate for hospices, it'll adopt the new acronym of CLEC-PAL, PAL being for palliative care. So once we've commenced with the study day, the 12-week implementation period then progresses, and throughout that time we collate clinical feedback data. So this could be on various things such as staff engagement, any issues that are arising, and any modifications to the strategy. We then repeat the first process, pre-implementation, post-implementation, and of course we analyse all of that data that we collect. We repeat this entire process at 3 of our participating hospices. Now, due to COVID, unfortunately, one of our hospices was closed to admissions for a considerable length of time. And so we were fortunate that we were able to recruit another hospice to replace them, but the original hospice was still keen to retain engagement. So now they're open to admissions with a reduced number at the moment. We're able to carry out this first part of the process. And this is actually really important to demonstrate that we're able to collect this data for a future definitive study, because this hospice is part of a number of hospices across the UK, so we're able to demonstrate that we can collect that data. So having a look here, just some of the results, as I say, these are preliminary results at the moment, and this is one complete data set that we have from one hospice. If we look at screening here, you can see that it didn't take place at all pre-implementation, and it's actually increased by 50% post-implementation. Now, I've since been told that they've actually made a modification to the software. It'll prevent the patient case record actually being saved unless the 4AT screening tool's been taken place. So that number, of course, will rise. You can see here the majority of the metrics actually are an improvement post-implementation, with the exception of here, we've got total length of admission and proportion of delirium days, where we can see a slight increase post-implementation. But this is a feasibility. It's not powered to detect effect. This is just one data set from one hospice, and there could be a variety of reasons why we're actually seeing that increase there. So moving on to work package 3, then the realist evaluation, where the aim here is to assess the acceptability and the flexibility of the CLEC-PAL implementation strategy. We're doing this through a survey, so we've got a modified version of the normalization measure development on NOMAD survey, and we distributed this in electronic and paper format. And it runs until the day before the study day, which marks the beginning of the implementation period. And then we distribute it again post-implementation. So, of course, we can compare views pre- and post-implementation. Also, post-implementation, we're carrying out some semi-structured interviews with a topic guide, again, informed by normalization process theory. And, of course, we'll analyze all of that data. So, again, this is one complete data set we've got from one hospice, and we can see a sample of some of the survey questions here. And we have, my hospice has a delirium guideline based on the NICE guideline. And we can see pre-implementation that 35% correctly answered no, they didn't have a guideline. And this increases to 63% correctly answering yes post-implementation, which is starting to give us an indication that knowledge is starting to disseminate through the hospice there. So when we looked at staff in the hospice having a shared understanding of both the purpose of the guideline and also of the implementation strategy, again, we can see an improvement in agreement post-implementation. The final one I wanted to just point out here is, as Miriam mentioned, sustainability. CLEC-PAL is a sustainable implementation strategy. Now, agreement for this was very low pre-implementation, and it's actually risen to 63% post-implementation, which is a real positive indicator there. So, moving on to the interviews. So we've now completed interviews with staff and management at one of our hospices, but we've yet to actually analyse the data. But I thought I'd just share with you some really positive quotes that we've got from some of these interviews with staff with various different roles during the interviews. And then finally, just to summarise, in terms of feasibility then, in challenging times, we've retained excellent engagement with 3 of our participating hospices, and we've recruited an additional hospice. To date, we've collected data from 170 patient case notes, and they have a variety of different formats. So that's fully paper notes, hybrid paper and electronic notes, and fully electronic notes. And of note, with the fully electronic notes, we've also explored the ability to remote access this data. So with permissions, I can go to a local GP practice where we're then able to remotely access the clinical records. And this is, again, a really crucial thing to demonstrate for a future definitive study with multiple hospices across the UK, as it'll significantly reduce data collection times. So to date, 0 patients have elected to opt out. The pre-implementation survey is now completed in all 4 hospices. The in-person study days have taken place in the 3 hospices where the feasibility with the implementation will run. And it's actually been completed in 2 of those 3 hospices, the implementation period, and it's currently ongoing in our 3rd and final hospice. And then one hospice has actually completed all of the study requirements. They've actually elected to continue the CLEC-PAL strategy. In fact, I don't think it's an exaggeration. We're actually really proud how they've taken ownership and sort of built on the foundations that they acquired through the study. They're currently developing a monitoring and evaluation framework as part of the sustainability aspect of the CLEC-PAL strategy. So we think that's a really positive outcome there. So that brings me to the end of this presentation, and I welcome any questions. Thank you.